All right. Are we ready to try to take a look at some strips now? The first set of rhythm strips that we want to look at, or the first set of rhythms that we want to identify, are what we call sinus rhythms. So let's get our shared screen going on here. And let's look at sinus rhythms. So sinus rhythms are the first of the rhythmogenic areas that that can generate a rhythm. When we say that a rhythm is a sinus rhythm, we are implying that the SA node is initiating these rhythms, okay? So we're implying that the SA node is initiating these rhythms. It is the first of our supraventricular rhythms. So rhythms can be broken up into two broad categories, supraventricular and ventricular. Supraventricular means that the pacemaker is starting somewhere in the sinus node, the atria, or the junction, and it is initiating a normal QRS complex. Remember that the PR interval has all activities, all autorhythmic activities are taking place before the QRS complex. So anything that can be initiated anywhere from the areas that would come within that PR interval are supraventricular. And then ventricular means that the contractile cells of the ventricles are initiating the rhythm. Of the supraventricular rhythms, there are three areas that it can be initiated from: sinus nodes, the sinus node, the atria themselves, or the junction. All of those will initiate a supraventricular rhythm. Today, we're going to talk about sinus rhythms. So in sinus rhythms, they all originate from the SA node if it's called a sinus rhythm. Otherwise, it wouldn't be called a sinus rhythm. The only major difference, or the big differences in the different types of sinus rhythms, are the rate and regularity of the rhythm. But the common things in all of them is that they have all the P waves are identical, all the PR intervals are identical, and the PR interval is within its normal time frame, the 0.12 to 0.20. In leads 2, 3, and AVF, the P waves are upright, and in V1, they are inverted, always, if it's coming from the SA node, okay? All right. So the characteristics, first of all, of a normal sinus rhythm, here's kind of the four general rhythms that come from the SA node. We have a normal sinus rhythm, sinus bradycardia, sinus tachycardia, and a sinus arrhythmia. A normal sinus rhythm is one that has all the P waves identical, the PR intervals identical, and are within the 0.12 to 0.20. And the heartbeat, the R to R intervals are regular. The P to P intervals are regular and they match. And that rate is between 60 and 100 beats per minute. Bradycardia is identical to a normal sinus rhythm, except its rate is less than 60. Sinus tachycardia is identical to a normal sinus rhythm, except the rate is greater than 100. And a sinus arrhythmia is identical to a normal sinus rhythm, except the rhythm is irregular. And then we can have a bradycardic sinus arrhythmia, a tachycardic sinus arrhythmia, or just a sinus arrhythmia. So in a normal sinus rhythm, the rate's 60 to 100. It's got its regularity is regular. P waves are present in sinus. The P to QRS ratio is 1 to 1. The PR interval is normal and constant. QRS complexes are normal and narrow. There is no grouping because all the QRS complexes are present, and there are no dropped beats. A sinus arrhythmia is exactly like a normal sinus rhythm, except the regularity is off. Most of the time, the most common reason why we have a sinus arrhythmia is that it varies with respiration. In fact, the more fit and healthy a person is, the more of a sinus arrhythmia based on respirations they have. There are a couple reasons why we could have a sinus arrhythmia, but it is important to, and we'll talk about both those, but it's important just to note that all of it still originates from the SA node. The PR intervals are still constant. All the P waves are still constant, but the P to P intervals vary. and they typically vary at greater than or equal to 0.16 seconds on an EKG strip. So the P to P interval is going to vary by a pretty large margin. There is some small variance that you might have in a normal sinus rhythm without being able to call it without having to call it a sinus arrhythmia. But certainly if the P to P intervals vary by more than 0.16 seconds on a strip, then you have a sinus arrhythmia. What do I mean by that? I mean, you take your P to P interval and match it to another P to P interval. And if the difference between those is greater than 0.16, you have a sinus arrhythmia. The two types of sinus arrhythmias are respiratory or phasic, or non-respiratory or non-phasic. The respiratory sinus arrhythmias will change based on respirations. The non-respiratory sinus arrhythmias are arrhythmic and have no tie to your respirations at all. So on the respiratory sinus arrhythmia, every time you inhale or exhale, it changes the speed of your EKG. So as you inhale, the rhythm changes, and as you exhale, the rhythm changes. You inhale and it tends to speed up, you exhale and it tends to slow down. And you can follow the pattern with their respirations. You can watch the EKG and watch their respirations and it will match. That's the most common cause of a respiratory arrhythmia. So on inspiration, it speeds up. On exhalation, it slows down, and it follows a pattern. So even though it is arrhythmia, the arrhythmia is irregular, it still follows a pattern based on respirations. That also means that this particular arrhythmia is not pathologic. This is normal, and again, it is more apparent in people who are healthier and more fit. The non-respiratory sinus arrhythmia is not normal, and it is a sign of pathology. Usually ischemic cardiac disease. It also can be normal in elderly because they are having a little bit of changes in their physiology and a little bit of damage in their heart as they get older. There's no definite pattern. The P waves and the PR intervals are still sinus, but there's no pattern to the speeding up and slowing down of the arrhythmia. And this is a sign of pathology. So it is important if they have an arrhythmia for you to determine if it's respiratory in nature or not. The etiology of sinus arrhythmias, it's a normal variant in most people based on the respiratory cycle. It can also be caused by enhanced vagal tones. So as we bear down, you can start to see a little bit of an arrhythmia start to form in. And the clinical significance is either nothing, there is no clinical significance because it's normal, or it could be pathology because of cardiac disease. So you have to determine if it's respiratory or not. Treatment for it is either none because it's normal, or you need to treat the underlying cause that they're experiencing that's causing the arrhythmia in the first place. So usually the ischemic disease that they're having. Bradycardia is exactly like a normal sinus rhythm, except the rate is under 60. The etiology of sinus bradycardia is usually there's an increase in vagal tone. That could be transient, like vomiting or carotid massage or something to that effect. It also could have, someone that's having an MI can have a sinus bradycardia. Increases in intracranial pressure can lead to bradycardia. If you'll go back and remember your Cushing's triad. Other types of things, blood hypoxemia, so lack of oxygen within the blood, decreased ventilation, and so on, and a slew of drugs and other kinds of things. It also can be, and quite often is, number 10 there, normal healthy finding in people who are healthy and fit. So just because someone has a bradycardia does not mean they have disease. Make sure you do a good history. So for example, my resting heart rate is between 48 and 52 beats per minute. And I would greatly appreciate you not going to an ACLS algorithm on me. So it just depends on what's normal for that person. Normal parasympathetic involvement and healthy parasympathetic involvement will start to lower the person's heart rate below 60, and you'll have a sinus bradycardia as a normal variant. The clinical significance, It might result because of, or might cause a decrease in cardiac output, or it might cause hypotension or other types of symptoms if it came from a pathologic reason to begin with. Or in healthy people, it might have no significance whatsoever. And then the treatment, of course, is going to be dependent on signs and symptoms. If there are signs and symptoms, treat those. We often will treat those with atropine and catecholamines. You'll learn that in ACLS. And if it's normal and healthy, then please don't treat them at all because they're normal. Sinus tachy is all the definitions of a normal sinus rhythm, except it's going greater than 100 beats per minute. Okay. You also might see something called electrical alternans in tachycardias. This is normal in a lot of tachycardias. And it has to do with this pattern that we see in the QRS complexes, where the QRS complexes are normal in terms of their rhythm, but you see a difference in their amplitude, where every other one changes its amplitude. And they get big, small, big, small, big, small, or they can even kind of fall into a pattern of getting larger, then getting smaller, then getting larger, and then getting smaller over a series of complexes. And this has to do with kind of a axial change in the heart, often because there's a physical change in the heart because it's beating so quickly. And because it's beating so quickly, as the heart is beating so quickly, it also has a slight little tilt to it as well. And it kind of shifts the axis just a little bit on each beat. And so you might see a fluctuation in the electrical axis, and it shows up as that electrical alternans, where you see different size QRS complexes, but in a very common pattern, and it doesn't change the rhythm. And that can be a normal variant that you see in a lot of tachycardias. You also might see some changes in what's called the TP wave. This is a wave that we don't commonly see. I mentioned it way back in one of the previous presentations I did. But the P wave is the atrial depolarization. Something called the TP wave is the atrial repolarization. We don't ever see that. When it happens, it's usually tucked up inside the QRS complex, and it is very small anyway. So we really don't ever see the repolarization of the atria. However, in some tachycardias, the QRS complex is going fast enough, and we start to see kind of a change in the PR interval because of the sympathetic involvement. And so every once in a while, that TP wave can actually happen in a retrograde manner to the QRS complex. And what it can do is sometimes it shows a depressed ST segment that is actually not really a depressed ST segment. It's actually the TP wave. All that means is that it can make it difficult for us to actually tell that someone has ST depression when we're talking about a tachycardia. So it can just make analysis a little bit more difficult. Etiologies of sinus tachycardia, anything that's giving you a sympathetic tone or increase in sympathetics, which means it could be absolutely normal, or it could be a sign of other activities, exercise, anxiety and stress, fevers, drug induced in some fashion, something that's causing a drug induction. So all kinds of different things can lead to a tachycardia, but the critical component there is almost always there's a sympathetic component that is going on as well. Clinical significance, if it's not exercise based and there's a difference in exercise physiology compared to normal physiology. So do not, we need to skip exercise when I say the following thing. In a person who is not exercising, a heart rate greater than 140 can actually start to decrease their cardiac output. If they're exercising, there's other means by which they're getting that cardiac output, and other means by which they're getting their energy sources. But in a non-exercising individual, if they have a heart rate greater than 140, it can start to decrease their cardiac output, and that can become a problem. It can start to precipitate ischemia or even infarct. So if it's greater than 140, we would say that they have a rapid ventricular response. Their ventricles are moving along quite rapidly, and it can cause some problems. So greater than 140 in a resting patient, a patient that is not exercising, is something to be concerned with. And then our treatment is going to be to treat whatever the underlying cause is, or in some cases, we'll directly treat the rhythm itself to get it to slow down. And we'll discuss the differences in those as we go along. Okay, so those are the rhythms. The rhythms are normal sinus rhythm, sinus bradycardia, sinus tachycardia, sinus arrhythmia. Now we have two versions of crap. We have two things that are in a rhythm to look at. A sinoatrial block is something that happens within a sinus rhythm. So if we have a sinus rhythm, we can have a sinus block as well. A sinoatrial block is if we have a dropped cardiac cycle. We have a dropped cardiac cycle that is dropped in time. So what we have here is we have a normal cardiac cycle. The cardiac cycle is a P, QRS, and T wave. We have a normal cardiac cycle, and then we have nothing. Something is gone there, but then it comes right back and it's normal again. And that's what we call a sinoatrial block. In a sinoatrial block, the blocked signal is a direct multiple of the actual rhythm itself. In other words, if we do our calipers, here's my caliper from this P to this P, and then it should have happened here, and then it comes back here. So if this is my blocked cycle, if the next cardiac cycle after the block comes back in on time, then we call it a sinus block. What that means is that the sinus node fired, but after it fired and before it got into the atria, it was blocked. That means the sinus node was not ever reset. So remember that the sinus node fires before the P wave. So here we had the sinus node fire. Here we had the sinus node fire. Then here we had the sinus node fire, but it was blocked and it never entered the atria after it was blocked. So we have nothing that happens that we see, and then the SA node fires again. We know that the SA node was not reset because this next cardiac cycle after the block comes back in time. And it doesn't matter how many cardiac cycles were blocked, whenever it comes back in, if it comes back in time, then we had a block, what's called a block. So the pause is an exact multiple of the P to P interval. A sinus pause, on the other hand, is exactly the same thing. However, the cardiac cycle after the pause does not come back in time. It comes back either before or after it was supposed to. And that means the SA node was reset. That means during the dropped cardiac cycle, the SA node was stopped altogether. That means the SA node didn't fire at all, and it was reset by something. Well, that's a terrible picture. Sorry, I'm not sure why that's not coming up, but in the end, the pause is not an exact multiple of the P to P interval, okay? So there's that. I'll try to show you both of those again in just a minute. That's a sinus pause. So a sinus block is where the cycle after the dropped beat comes back in time. And a sinus pause is where the cycle after the dropped beat comes back in, not in time, at some other time. Then we have what's called a sinus arrest. A sinus arrest is the same thing as a sinus pause. However, we have multiple dropped beats. There isn't an exact way to look at that, but what I'll have you use is if there are 3 dropped cycles, then we'll call it a sinus arrest instead of a sinus pause. It's a sinus pause that has got a prolonged block, a prolonged pause, okay? So again, there isn't a clear cutoff between a sinus pause and a sinus arrest, but we're gonna use 3 P-to-P intervals as our rule. So if there are 3 dropped complexes, then we will call it an arrest. If there are 1 or 2 dropped complexes, then we will call it a pause. The etiology of either the pause, arrest, or block, often this occurs because the sinus node is either failing to just discharge, that's the arrest or the pause, or the discharge is blocked soon after, and that's where it's called a block. You might have a sick sinus syndrome, so the sinus node is actually damaged somehow. If someone has excessive vagal tone in a given time, it can stop the SA node from firing properly. Coronary artery disease or inferior wall MIs tend to cause it. Hypersensitivity to the carotid sinus node can cause it. A lot of different things. Digoxin, this drug down here called digoxin, you're going to see show up a lot in our arrhythmias. So that's another one that can cause it. Ooh, sorry about that. So that's another one that can tend to cause it. So there's lots of things that can lead to a sinus arrest, pause, or block. The clinical significance, if there is a frequent or prolonged periods, then it can actually result in a decreased cardiac output because we don't actually have a QRS complex there, which means we're not actually having a contraction occur. So there's one thing. Another thing is that prolonged episodes can lead to escape rhythms starting to come in. Treatment, it depends. If they're asymptomatic and it's only happening once in a while, there might not be any direct treatment you do other than transporting them. But if the rhythm is becoming a symptomatic bradycardia, then we'd have to treat it for the symptomatic bradycardia that it is. And again, you'll learn the treatments in ACLS. Okay. Those are our sinus rhythms. We have 4 sinus rhythms and 2 sinus craps. Normal sinus rhythm, sinus bradycardia, sinus tachycardia, sinus arrhythmia, and then the craps are sinus block, sinus pause, and arrest. Sinus pause or sinus arrest. How that works, when we talk about crap being added into the rhythm, then we name the rhythm and then list the abnormality, the crap. So if I have a sinus block in the rhythm, I would name the rhythm first and then say with, and then list the blocks. If I have a sinus block, I would say I have a sinus rhythm with a sinus block, or I have a sinus bradycardia with a sinus block, or a sinus tachycardia with a sinus arrest. So the block, pause, arrest is something that follows the word with, and the other things are the name of the rhythm itself. So you name your rhythm. You've learned 4 so far: normal sinus rhythm, sinus bradycardia, sinus tachycardia, or sinus arrhythmia. And then you name any of the abnormalities after the word with, and we'll practice a lot of that. I will say this in terms of etiquette, to call something a normal sinus rhythm, technically it needs to be normal, which means it has to be regular and it has to not have any abnormalities in it at all. If it's a rhythm that has abnormalities in it, then we tend to drop the word normal. So if I have what would be a normal sinus rhythm that also has a sinus pause in it, then instead of saying a normal sinus rhythm with a pause, I would say I've got a sinus rhythm with a pause, and I would skip the word normal. The fact that I didn't use the words bradycardia or tachycardia lets me know that the rate is between that 60 to 100 in the first place. Okay, there are our sinus rhythms, and boy, get ready to start practicing a whole lot of sinus rhythms, a whole lot of rhythms in general. Thanks, and I'll see you soon.